Now, biliary ascites. Now we come on to certain interesting causes for ascites. So, biliary ascites is basically a spontaneous perforation of the common bile duct. Most commonly, the junction between the cystic duct and the common bile duct. So, as a result of this, bile collects within the peritoneal cavity. Okay. So, find that biliary ascites can also occur because of a spontaneous CBD perforation, or else can occur because of perforation involving the gallbladder, can occur because of a perforation involving the cystic duct also. Okay. It is very important to understand few causes for this biliary ascites. So, more often than not, there may not be any underlying cause. Well, few speculated causes include presence of a distal duct obstruction, possibly. A pancreatic fluid reflects into the biliary tree, causing a weakening of the biliary tree. Maybe that could also be a cause. Pancreatico-biliary malunion or maljunction could be a cause for it. Sometimes they say that when you have a pancreatic wall, inherent defect in the pancreatic wall can also result in the perforation spontaneously. So, sometimes what happens is that the amount of bile that gets collected over a long period of time within the subhepatic region, it can get walled off by peritoneal reaction, producing a walled off pseudocyst-like picture. So, this can mimic a congenital choledochal malformation. So, congenital choledochal malformation. So, it is very common to get in such spontaneous biliary perforations in infants and toddlers, more common among infants and toddlers when compared to older children. Generally, they present with painless abdominal distension. That is the most important thing. Generally, we expect pain to be there if there's a perforation, biliary leak. Here, the pain is the distension is predominantly painless with worsening jaundice. They can have vomiting, abdominal pain, occasionally maybe a dull aching pain, and clay-colored stools occasionally. The abdominal distension is one of the most, like I said earlier, the abdominal distension, it is very difficult to differentiate this particular distension from distension due to other causes. They can also present with hydrocele, which might contain a bile-tinged fluid. Generally, in children especially, the capacity to contain bile within the peritoneal cavity is very high. So, peritonitis may not usually be present, but it can occur, of course, biliary peritonitis can occur. The most important thing which would help us in differentiating initially at least, in say in an ultrasound or any other investigation, one important point which will help us in differentiating it from hepatocellular ascites or hepatic ascites is the absence of an underlying liver disease. So, there will not be any underlying liver disease in the case of a biliary ascites. So, the imaging techniques that we can make use of include an ultrasound abdomen. So, an ultrasound abdomen will give you the presence of echogenic fluid. Usually, it may be echogenic in nature, so echogenic fluid within the abdomen. The gallbladder, we can see if it is dilated or collapsed. Sometimes pericholecystic fluid might be there, collection may be there. There can be a large pseudocyst-like collection in the periductal region, etc. So, all these features can be made out in an ultrasound abdomen. So, a very important investigation which can help us which can give us an idea regarding the site of perforation would be to do an MRCP. So, here we can see that there is a spontaneous biliary perforation resulting in extravasation of bile into the surrounding tissue, causing biliary ascites as well. And this is a tube drain which has been placed to drain out this extra bile that is noted inside. Hepatic scintigraphy is also very useful to identify the present site of leak and the extent of leak. So, this is a person with a child with a spontaneous biliary perforation causing biliary ascites. You can see there's extravasation of the radionucleotide into the peritoneal cavity. So, like in all other cases of ascites, paracentesis will more or less clinch your diagnosis. So, if you do a paracentesis, the fluid will be bile tinged and will contain bilirubin levels of more than 100 to 400 milligram per ml. Now, the treatment options. So, what are the treatment options available for biliary ascites? The most important thing is to go for an external drainage. So, the bile within the peritoneal cavity has to be drained. So, this can be, this is done via an abdominal approach. You go via a subcostal incision, enter inside. You can, if you're able to, if you see the bile leak that is noted, the ascites that is there within the abdomen can be drained out. If you want to see the site of perforation, we might not always be able to make it out. So if you have to make it out, we might have to do a cholecystotomy and a cholecystography to identify the site of perforation. If this perforation is located within the cystic duct, we can proceed with a cholecystectomy, which will more or less take care of it. If the perforation is located anywhere else, say for example at the junction between the cystic duct and the common bile duct, or within the common bile duct, etc., that area will usually be too sodden and inflamed for any definitive, dramatic procedures to be performed. For example, like if you want to do a hepatoenteral anastomosis, it will be very difficult in such settings of a biliary ascites, because the entire area will be inflamed and friable. So in such cases, we might have to do only a tube cholecystostomy, drain out the bile, and then come out. So very rarely we might encounter a perforated choledochal cyst, in which case we can attempt to do a hepatico-enterostomy, hepatico-jejunostomy. ERCP stenting is a very good option, especially slightly older children. But the problem is negotiating the stent across the perforated site will be a little bit difficult in children. So what happens if you leave these children alone? So if you put in a drain to drain out all the bile that is there, give a wash and then come out, it takes around, the perforated site heals in 80% cases within 3 weeks. So in those cases which heal, there are complications that can occur. You can have bile duct stenosis at the site of injury. If there's bile duct stenosis at site of injury, what happens is that bile stasis occurs above. Bile stasis occurs, there's increased chance of stone formation. So these are stone formations that can occur. Okay, so these are some of the complications that can occur with respect to biliary ascites.